Next, we are going to hear from Dr. Pushpa Narayanaswamy. She is a neuromuscular neurologist and associate professor of neurology at Harvard Medical School, vice chair of clinical operations, Department of Neurology, Beth Israel Deaconess Medical Center, Boston, Mass. She received her medical degree from Bangalore Medical College, India in 1984, and she completed neurology residence at the National Institute of Mental Health and Neurosciences, Bangalore, India in 91. She moved to the States in 95 and completed another neurology residence, followed by a fellowship in neuromuscular disease at the University of Tennessee here in Memphis. She serves on the Medical and Scientific Advisory Board of the Myasthenia Gravis Foundation of America. And in her clinical practice, she manages neuromuscular conditions with special emphasis on myasthenia gravis, myopathies, and muscular dystrophies. Her broad area of research is in health services and includes dissemination and implementation research and comparative effectiveness research. Her major clinical research interest is MG, and her advocacy work seeks to incorporate health service research with healthcare policy to improve patient care. All very important attributes. So thank you so much for being here. I will go ahead and let you present your slides.
And thank you for that very kind introduction. So let me share my slides here. Okay, so we are all ready to go. And good afternoon, everybody. And so this is almost a tag team to Dr. Guptill's earlier talk. So he talked at a very high level about the disease itself, the challenges of research in the disease. I'm really going to focus on what's going on now and give you some of the results of the trials that he was talking about the newer treatments and some other information as well. These are my disclosures. So what am I going to talk about today when I talk about updates in the management of myasthenia gravis? I will touch first upon the international consensus guidance for myasthenia gravis management. And then I'll talk about some of the recent large trials of drugs and other agents, other therapies that have really changed the management of myasthenia gravis. I'll talk about the trial of thymectomy that was published in 2016. I will talk about the data for REGAIN, that is the trial that studied eculizumab and resulted in its approval in 2017 by the FDA. And then I'll talk about the data of the ADAPT trial that was also mentioned. This is efgartigimod, which is an FcRn antagonist in generalized myasthenia gravis. And this is a phase 3 trial as well. And then we have data from phase 2 trials of other drugs, zilucoplan, which is a complement inhibitor, rozanolixizumab, which is also a complement inhibitor, and then Vivacity MG, the phase 2 RCT of nipocalimab, which is an FcRn antagonist that was just published. And Dr. Guptill mentioned the PROMISE MG study, of which I am the co-primary investigator. I will not touch upon that. And they'll talk about some data, recent data about some of the older drugs that we've used in the past. I don't think I'm going to touch upon therapies in the pipeline because Dr. Guptill summarized those in his talk. So this is our 2020 update that was published in the Neurology Journal. It's open access and anybody can get it if you just type in myasthenia gravis consensus. You may get the 2020 and the 2016. But this whole story about developing a consensus guidance started in October 2013 when the Myasthenia Gravis Foundation of America appointed a task force to develop treatment guidance for myasthenia gravis. We then had a panel of 15 experts representing 9 countries, and we used a method of formal consensus. So this was not just a simple vote, this was a mathematical formal consensus to develop recommendations for myasthenia gravis. And because of the development of, or because of results from a few other studies over the next few years, we revised this and updated this guidance, and that was the 2020 update. So when we talk about management of myasthenia gravis or treatment of myasthenia gravis, the first question that we have to ask is, what are the treatment goals? What are our goals when we treat patients with myasthenia gravis? And Dr. Rampal from Alexion sort of mentioned this briefly in passing in our discussion, but basically we look at two aspects, and we want the disease to be controlled and we want the side effects to be minimal or none. So that's a really, really high bar. But I think all of us have to remember that we should not accept a lower bar. We should work very, very, very hard towards getting every patient to that high bar. So what do we mean by minimal manifestations? So in terms of disease control, we are looking for minimal manifestations. So after a treatment, a patient with myasthenia gravis, a person with myasthenia gravis, has no symptoms and is not functionally limited by the disease. But if I examine the patient in my office, I may find maybe mild weakness of eye closure, for instance. So that is post-intervention status, minimal manifestations, and they can be on medications at this time. It doesn't matter. But their functional status and their symptoms are not limiting to them. And then in terms of the other aspect of the treatment, which is the treatment side effects, we really want them to have mild side effects, which have really no symptoms or just mild symptoms, and for which we wouldn't do anything other than just watch them and not really change medication or do something else to treat the side effect. So this is a really high bar, but I think we have to remember that this is where we should be. We shouldn't stop before this. And I think we are getting to the point where we have more and more medications that will help us achieve that, even in some of the patients in whom traditional therapies can be difficult to achieve that goal in. So in the international consensus guidance for myasthenia management, we addressed symptomatic therapy, which is just basically mestinon or pyridostigmine, and we also addressed immunosuppressive therapies, including IVIG and plasma exchange. We addressed different types of myasthenia gravis, including musk myasthenia gravis in childhood, and myasthenia gravis in pregnancy. And in our new update, we addressed ocular myasthenia gravis. We also addressed myasthenic crisis and different forms of antibody-associated myasthenia gravis, mainly concentrating on musk myasthenia gravis. So let me start with what we said about thymectomy. So because the thymectomy trial came out after the first 2016 myasthenia gravis consensus was published. And so we had, once the results of the randomized trial of thymectomy were published, we then had other information that would help us to change our recommendations from the 2016 guideline. So this was published in 2017, and this took many, many years to complete. So what was this trial? This trial included patients with acetylcholine receptor antibody positive myasthenia gravis. That's because the thymus is supposed to play a role in the disease in this specific group of acetylcholine receptor antibody positive patients. And these were patients who did not have a tumor of the thymus called thymoma. So because if they had a thymoma, they would need surgery to remove the thymoma no matter what. So we're not looking at that group. We are looking at non-thymomatous acetylcholine receptor antibody positive generalized myasthenia gravis. And there were two treatment arms. The first treatment arm was prednisone alone. So they all received prednisone. And the second treatment arm, the patients received thymectomy and prednisone. So the thymectomy that was performed was a little bit different than most centers do now, because it was the open approach. So it was like a cabbage or a bypass grafting surgery where they split the bone open and looked at the thymus and removed it. Many centers, including mine, now do robotic or video-assisted procedures, which are somewhat different. So the second groups, and you see here in red, the second group received both the thymectomy and prednisone. Obviously, patients knew what they had received, right? You can't hide surgery from a patient. So they knew it. But the people who were looking at these patients and following them up did not know which group was what, because patients were meant to go in for their assessments with these high-necked shirts so people wouldn't see the scar. All patients. So if you see here, they looked at outcomes in 36 months, and they looked at two outcomes. So they looked at how much could each group reduce the prednisone dose. So as patients get better, even with prednisone, many of you know that we gradually taper prednisone. So the first group here, you will see receiving prednisone alone, gradually, this is the dose of prednisone in milligrams. Gradually, the dose was tapered, and it dropped by about 15 milligrams or so, if you look here. And in the thymectomy group, again, gradually the prednisone could be tapered based on their clinical response. And you'll see that the dose difference between the two, the thymectomy and prednisone group, was able to drop the prednisone more than the prednisone alone group. And this difference was about 32 milligrams in alternate day prednisone. I'm sorry, 32 milligrams. I said about 32 milligrams in the prednisone alone group and 54 milligrams. So about a 22 milligrams difference between the two groups. If you translate that into daily prednisone dose, that's 11 milligrams difference in prednisone dose, which I think is significant difference, because 11 milligram decrease in prednisone may make a significant difference in the side effects to the prednisone. The second outcome measure here was a quantitative Myasthenia Gravis score, which is a score that has 13 questions. Each of them can be graded 0 to 3 based on how severe they are. And the total score ranges from 3 to 39. So this score also, you will see that the prednisone alone group, both groups achieved a drop in the score, but the thymectomy and prednisone alone group achieved a greater drop. And this difference was 2.85 points. And a difference of 2.3 points was thought was a priori, before they started the trial, the authors, based on other data, said, if our patients have a 2.3 point difference in the thymectomy group, that means that's a clinically meaningful difference. It means it is important clinically to the patient. So it's just not statistical, but it's also clinically meaningful. And if you sort of want to look at this in a nutshell, at 3 years after thymectomy, basically for every 5 patients undergoing thymectomy, 1 additional patient had either no symptoms or functional limitations from Myasthenia gravis, that is, they achieved minimal manifestations. And so that's pretty good in terms of number needed to treat. This is called the number needed to treat. How many patients do I need to treat so that 1 patient will get better? 5 patients. And so, the number, if you need to treat hundreds of patients before 1 patient gets better, that's not great. So what did we say in the consensus? We said that in non-thymomatous generalized myasthenia gravis patients with acetylcholine receptor antibodies, that is the group that was looked at in the trial, thymectomy should be considered early in the disease. And in patients who fail to respond to an initial adequate trial of immunotherapy or have intolerable side effects, they should also be strongly considered for thymectomy. This is just the 2-year extension. So after the 3 years, they continued to evaluate some of these patients who were in the original trial. And I'm just going to quickly, so the blue is a prednisone alone, and the red is a thymectomy and prednisone. And you will see, so the number of patients here is very much less. The first trial had 60 patients in the prednisone arm and 66 in the thymectomy arm, so 126 patients. But not all of them came back for follow-ups. We talked about difficulty with coming back. Not all of them, just 50 people of the original large group completed the 60 months. So you've got to be careful there. But again, there was that same difference. So mean difference in prednisone was 12 milligrams less in the thymectomy dose per day. And the mean difference in the quantitative Myasthenia gravis score was also clinically and statistically significant. So I'm going to talk quickly about the BEAT-MG trial, which was a phase 2 trial of rituximab in acetylcholine receptor antibody positive Myasthenia gravis. These were 52 patients, again, non-thymomatous generalized Myasthenia gravis, who received 2 cycles of rituximab. And the point of the trial was to see how many patients who received rituximab and how many didn't receive rituximab could reduce prednisone, and what was the reduction in the two. But unfortunately, there was no difference in the dose of prednisone at 1 year in the two groups, the group that received rituximab and the group that didn't. So the conclusion was that in mild to moderate myasthenia gravis, rituximab is unlikely to have a steroid-sparing effect over 12 months. So we said the first one is from the older guidance, 2016, and there's no change in that because it appears to be quite useful in MuSK myasthenia gravis. So we said it should be considered as an early therapeutic option in MuSK myasthenia gravis, but we don't really know if it's useful in acetylcholine receptor antibody positive Mycena gravis, and maybe it's an option for some patients if they fail other treatments. The next drug I'll talk about is methotrexate. It's been around for many, many years. It's been used not usually as first-line therapy, but usually if patients fail azathioprine, and now I think if patients fail mycophenolate as well. Again, this was a steroid-sparing issue. So it was a 12-month trial. Some patients got methotrexate, others didn't get methotrexate. And these were all acetylcholine receptor antibody positive patients. And again, at the end of the year, there was no evidence that the addition of methotrexate caused a reduction in the steroid dose more than just the steroid or the other group of patients alone. So we said, again, although evidence from randomized controlled trials is lacking, again, this may be something that we may consider in patients with generalized myasthenia gravis who really don't respond to any other drugs. And I think with all of the newer drugs, these will have to be used carefully, because if we have stronger data for response, for instance, with eculizumab, then we would probably say, let's do eculizumab if the patient is the correct patient for eculizumab, rather than using methotrexate. So this is the eculizumab trial that I just spoke about. It's called the REGAIN trial. It's a phase 3 trial. It was published in 2017, and the drug was approved in 2017. It's a monoclonal antibody with affinity to the C5 complement component. So it's we talked about complement induced. It's a protein. Dr. Guptill mentioned this. It gets activated by the acetylcholine receptor binding antibody, and then it causes destruction of the neuromuscular junction. So basically, eculizumab prevents the activation of the terminal component of complement that destroys the neuromuscular junction. It is now approved for multiple diseases, again, going back to what I said about immunology and how its applications are quite broad. And it's given intravenously. There's an initial period when it's given every week, and then it's given every 2 weeks. So these patients were refractory patients. They had failed prior therapy for over 1 year, 1 year or more, with other immunosuppressive agents. And then, so they were randomized to either eculizumab or placebo for a 26-week period. And many of those are still in the extension trial that's going on now, which is open label. They all know what they got. Everybody gets the drug. So there are various ways of looking at results, but I think a good way to look at this is what we call this Christmas tree plot. So the blue is the eculizumab and the red is placebo. So this is the Myasthenia Gravis Activities of Daily Living score that some of you may be familiar with. It's a series of questions where we say, how's your swallowing, how's your droopy eyelid, etc. And so we believe that if there's more than a 3-point improvement in the ADL score, that is clinically meaningful to patients. That means they feel better. It's just not a number there. And you will see that 60% of patients who got eculizumab, improved by more than or equal to or more than 3 points versus 40% who received placebo. But what is more impressive is as you go up the graph and see 8-point improvement in the MG-ADL, which is huge. A fifth of the patients had an 8-point improvement in the MG-ADL, whereas only 6% of placebo patients received that point. Similarly, the quantitative myasthenia gravis score, this is a patient-reported outcome measure. Patients tell us how they're doing. The QMG is based on the clinician's examination. Even there, you will see a greater than 5-point improvement in 45% versus 19%. These results were statistically significant on both sides. And then as we go up, you'll see that the eculizumab group did better. Side effects were minimal, and there were no serious side effects. Now, this was a published study that looked at the long-term safety and efficacy of these patients who went on into the open label trial. So what was all that about? So if you look at the graph here, again, blue is eculizumab and red is placebo. Now, these are patients, this box here, so this is looking at ADL, and this graph is looking at quantitative myasthenia gravis score, QMG score. This first box here is what I showed you in the REGAIN trial, all compressed. So this is the first 26 weeks. You'll see that the scores dropped. So these scores, if there's a lower score, it's better. A higher score is not better. So a higher score means worse function. The scores dropped in the eculizumab patients much more than they did in the placebo patients. Now, right here at 26 weeks, the placebo patients all received eculizumab because this is an open label trial and everybody's going to get the eculizumab. And you'll see how right away, almost within 1 month, their scores dropped to meet those of the eculizumab patients. And then this has been carried on here. It's almost 2 years, 130, over 2 years, so 130 weeks right here. You will see that the numbers of patients are very few because the numbers that have received the drug for that many weeks are very few. So because they all joined at different parts of the trial because they finished REGAIN at different parts. So you got to be careful because this is just a small number here. But you see that the scores fell for both QMG and ADL and remained there until 180 weeks or further. So we recommended at that time that eculizumab should be used in the treatment of severe refractory acetylcholine receptor antibody positive generalized myasthenia gravis. But we also said that the role of eculizumab in the treatment of myasthenia gravis is likely to evolve over time, because of all the data that's coming out about the effectiveness, about the safety. But we also said that one of the serious side effects of eculizumab is meningococcal infections. So obviously this is in the product labeling as well. Patients have to get immunized. And future research on eculizumab is obviously ongoing. The second drug I'm going to talk about, how are we doing on time? We are okay. Is zilucoplan, which is also a complement inhibitor, but it's a subcutaneously injected complement inhibitor. This is the results of a phase 2 trial where there was a broad, unlike eculizumab, the REGAIN trial, these were not refractory patients. These were all patients with myasthenia gravis. I'm not going to go into the details of the trial, except to say that the main study period was just 12 weeks, and then they were followed, and then they went to a long-term extension, but this was the main study period, and now there's a phase 3 trial ongoing. So I'm going to look here at the Christmas tree plot because it's easy. At the 0.3 milligrams per kilogram zilucoplan, again, you'll see that the eculizumab patients, this is the 3-point clinically meaningful outcome for, this is the quantitative Myasthenia Gravis score. And there were cumulative proportions. So if you look at the placebo, this is a smaller group than this. Now, this study was looking mostly at safety, not at efficacy, but there was still a signal for efficacy. If we look at something called minimal symptom expression with 0.3 milligrams per kilogram of zilucoplan, that is, their MG-ADL score is 0 or 1, which is they're doing great. You will see that placebo was about 15%, this is about 35, 36%, and so on. This was the phase 2 trial of efgartigimod. So this is an FcRn antagonist that Dr. Guptal sort of discussed the mechanism of action of. So this is the phase 3 ADAPT study, which included acetylcholine receptor antibody positive, MuSK positive, and seronegative patients, a total of 167 patients. And the nice thing, the very unusual thing about the study, in addition to including these groups of patients, was the fact that the treatment is not given at a very scheduled way, every time the same way. All patients got 4 infusions every week, so the first 4 weeks. And then they could go on in the trial for 26 weeks. And whether they needed another treatment or not was based on how they did. If they did well, how long they did well. So as long as they did well, and there were specific criteria for this. So when you look at it, they defined MG-ADL responders, so responders as people who had a greater than 2-point improvement in the MG-ADL score for 4 consecutive weeks in the first cycle, within the first 4 weeks of, during that first cycle, that is that first 4 weeks of receiving treatment, and 67% compared to 29% of placebo patients were responders. And again, you will see the QMG responder rate was much higher. That is the primary outcome, and these are acetylcholine receptor antibody positive patients. So again, if you look at the ADAPT results for the efgartigimod, the improvement in the ADL score and improvement in the QMG score, you will see a much greater proportion receiving efgartigimod responded compared to the placebo group. Now, how about the duration of response? We said that these patients didn't always receive the second group within maybe another 6 weeks or so. But here, almost 35%, so over a third of the participants didn't need any retreatment for more than 12 weeks. So that's great because they maintained their improvement for greater than 12 weeks. So this is the study of rosanolixizumab. So this is an FcRn antagonist. So this is, the UCB manufactures this, and it's a subcutaneous monoclonal FcRn antagonist. So this is a phase 2 study where there were trends to improvement, but there was no safety signal. It was safe. But there was some trends to improvement that did not meet statistical significance. So you'll see that the proportion is higher, but the primary outcome was not met. The last study I'll talk about is the Vivacity Study that was just presented at the American Academy of Neurology meeting. This is a phase 2 study. Dr. Guptal presented the results. This is nipocalimab, which is an intravenous FcRn antagonist. And again, here you will see they had multiple doses. They were trying to see which was the first dose. So this is MG-ADL change, and you will see that this was their primary endpoint. So this was at 8 weeks. So you'll see that a couple of the doses, the patients had good improvement, 3.9 points, which is clinically meaningful. 2.5 is also probably clinically meaningful. Phase 3 trials are ongoing. I'm going to skip this in terms of the depleting agents. Let's see. Okay, so I'm done. I think maybe we have some time for questions, about 4 minutes maybe.
Thank you so much. So I had a question. This person was wondering if head drop is a symptom of MG. She also has Parkinson's, so she didn't know which one that might be related to.
Yes. Oh, that can be difficult, but yes, certainly head drop is a symptom of myasthenia gravis. Some patients with Parkinson's disease, as you said, can have a head drop and even be bent in their spine. So, so it can be quite confusing, especially when both the diseases are going on in combination, which is pretty rare. The way to differentiate the two is that in myasthenia gravis, the head drop occurs, there is that fatigability of neck muscles. So when you've been sort of sitting up and looking at a computer screen for a while, or you've been looking up consistently for a while, you can't hold the neck up again. And so it comes up, it touches your chin, can't hold up your neck, and then it rest it a while, and then you can continue to look up. In Parkinson's disease, on the other hand, the stoop is most prominent when you're walking, and you can actually bring it up temporarily. It's not so much a weakness as an inability to maintain posture. And when we examine patients with myasthenia gravis, there's more weakness of the neck muscles in myasthenia gravis than there is in Parkinson's. Very good question.
Thank you for clarifying that. Is a thymectomy still recommended for seronegative patients?
Yeah, so it can be hard. So I think thymectomy still remains in the armamentarium of treatment options for patients with clear seronegative myasthenia gravis that do not respond to other therapies. But we've got to be careful in selecting patients. And the data varies. There are studies that show that patients respond to seronegative patients do respond to thymectomy. But we don't have strong data, but yes, absolutely. If nothing else works, thymectomy can be considered in those patients.
Perfect. Okay. I don't see anything else that has come through either box. So thank you so much for all the work that you're doing in the MG field. We definitely appreciate it. A lot of people were very grateful for all your work and effort that you're doing.